Good afternoon, everyone. This is Sharon Terry. I'm President and CEO of Genetic Alliance, which brings you this series on privacy and progress in whole genome sequencing. We're very glad you could attend today. Today we're going to look at Recommendation 5. So this is actually our seventh webinar. We've done 6 of these. This Recommendation 5 looks at public benefit. So we know that thousands of citizens have already participated in whole genome sequencing, even more than when the Commission wrote its report, and that everybody who does participate needs to have a pathway through understanding what this means, what are the benefits, what are the risks. We, in the medical community, certainly look at these advances to figure out how can we benefit from understanding genomes and the issues around genome sequencing. So in Recommendation 5, the Commission, I'm going to read the recommendation which is on your screen. The recommendation encourages the federal government to facilitate access to the numerous scientific advances generated through its investments in whole genome sequencing to the broadest group of persons possible to ensure that all persons who could benefit from these developments have the opportunity to do so. So today, we are going to look at this public benefit issue, which ultimately is the ultimate question after all, and while all of the other webinars certainly have been important, this one comes kind of to the meat of it where the rubber hits the road and lets us start to understand how do all sectors benefit, how do we make sure we aren't creating more disparities, how do we make sure that we're maximizing benefit and reducing risk. The webinar runs in this manner. There are many of you on the webinar, and so we're unable to open the lines for questions. We instead offer you the opportunity to type in the question box on your little sidebar from the GoToMeeting webinar software the questions you have. And we recommend that you do that throughout the webinar, partly so that we can organize those questions in a way that makes sense and so they're not duplicative, but also so that you can get them in. We usually have quite a number. We try to get through all of them. If we don't get through all of them, I will try to follow up with the speakers and get the answers to you afterwards. We're very fortunate to have some wonderful speakers today. I will introduce all 3 of them with very short descriptions of who they are and where they come from. They can certainly say more about that when they tell us their perspective with regard to this question. And they will go in this order. So first, you'll be hearing from Retta, who's a patient advocate and runs the Beerys Dystonia support site. Then you'll hear from Pilar Ossorio, who's an associate professor of law and bioethics at the University of Wisconsin at Madison.
As Sharon said, my name is Retta Beery, and my contribution to this discussion is on a personal level. My twins, Noah and Alexis, in the background of this slide, were born in 1996. Our older son is standing in front of them. They came into this world in a normal delivery, and we brought them home, and we immediately noticed that they had some severe issues with colic and developmental delays. So we started down a process of taking Noah and Alexis to specialists. In 1996, we started with a pediatric neurologist, and then we went to other specialists like a pediatric gastroenterologist, and pretty soon we found ourselves in a world of specialists and tests and unknowns. And this is a slide that shows some, if not most, of the tests and the specialists that we saw from 1996 to 2002. So the first 5.5 years of their life. On the left-hand side of the screen, you can see a lot of the specialists and testing that we had done for Noah and Alexis. And on the right-hand side of the screen are the results from all of those visits and tests and appointments. And our results from those were an incorrect diagnosis of cerebral palsy. We did a couple of MRIs on Alexis, and we never found anything of significance. And in 1998, we had an MRI done on Noah, and they found brain damage in the ventricle area of his brain. So that resulted in a diagnosis of cerebral palsy. We had a treatment that was centered around what we would later find to be an incorrect diagnosis of CP. And as you can imagine, there was a great financial, emotional, and physical cost that continued to mount in our family because of what we were dealing with Noah and Alexis. So this next slide shows pictures of where Noah and Alexis were at physically. And these pictures were taken when they were anywhere from 3 years old to 5 years old. And as you can see in a lot of the pictures, Alexis's eyes would roll up into her head. Her forearms would kind of stick up into her chest. Her hands would point down. She would tremor for hours at a time. Her eyes would roll up into her head for hours at a time, and you couldn't reach her. And then on the other hand, Noah's presentation, he drooled substantially, and he had a completely different set of symptoms. And then in 2002, I had done research for about 4 years, and I found an article titled Deaf Diagnosis, Sagawa's Dystonia mimics cerebral palsy, but it's treatable. So this was the first step in finding a new diagnosis for Noah and Alexis. When I read this article, there was a common thread that separated this other disorder from CP, and Alexis fit this particular symptom. So when she would wake up in the morning, she was able to walk. Although it was hard for her, she could walk, but by 10:30, 11 o'clock in the morning at age 5.5, she could no longer walk. She could no longer sit up. She could not swallow food. So we were actually looking at wheelchairs. We were talking about feeding tubes. She had lost 20% of her body weight the month before I found this article. So when I found the article, I knew that she fit. We took Noah and Alexis to Dr. John Fink that the article was centered around out of the University of Michigan, started Alexis on the drug L-Dopa, and she went from wheelchair-bound and feeding tube-bound to being able to walk and talk and function, doing things that we never thought she would be able to do. We never thought she would live independently, and within a month, she was playing soccer. And we put her in gymnastics within 6 months and dance. And a few months after we started Alexis on the drug, Noah's symptoms, his onset started. His right foot started to turn in. His head started going down. He started drooling. And so this is a progressive disorder. It just gets worse until it robs you of your ability to function. So we ultimately started Noah on the drug L-Dopa as well. And they were diagnosed with Sagawa's dystonia just based on a response to the medication. So this is Alexis in her little dance costume, and Noah playing soccer. These pictures were both within a year after starting on the drug. And Alexis in gymnastics. So in 2008, my husband took a job with Life Technologies. We had been living in Phoenix, Arizona at the time, and we moved to California because of the promise of what a company called Invitrogen, who was getting ready to acquire Applied Bio, had, and that was a tool called a sequencer, a genomic sequencer that would one day be able to diagnose kids like Noah and Alexis at birth. So I had started a website in 2003. We had reached people around the world that had been misdiagnosed, people that were in wheelchairs that couldn't function, they couldn't go to the bathroom on their own, couldn't eat on their own, would find our website, would find a media piece done on Noah and Alexis. They would reach out to us, start on the drug L-Dopa, and they would be playing tennis on their JV high school tennis teams, and have a lot of stories like that. So the idea that there was going to be a diagnostic tool available that would be able to diagnose kids like Noah and Alexis was exactly what we had been hoping for, because every time we reached people, we would always tell them the only way to be diagnosed was to see if your child or if yourself responds to the medication. So in 2008, we moved out to California, and then a year after we moved out here in 2009, Alexis had struggled with a chronic cough, and this chronic cough turned into a life-threatening breathing problem. Within the first 2 months of the struggle for breath, Alexis had gone to 7 emergency room visits. We had paramedics in our house on several occasions. As she was turning blue, they were trying to get her breathing again. And we were back in the world of a medical odyssey and unknowns and specialists and no answers. So for 18 months, I took Alexis to, on the left-hand side of my slide, you can see, again, not an extensive list, but certainly the majority of tests and doctors and specialists that we went to. And again, on the right-hand side, we got no answers. The physical, emotional, and financial costs continue to mount. And in the meantime, Alexis was inhaling racemic epinephrine through a nebulizer just to stay alive. And racemic epinephrine you can only get at the emergency room. It's not something that you want to inhale regularly, and she was inhaling it every day just to keep her vocal cords open. So we were waiting for answers. Alexis could no longer do, we had to pull her from all sports. She would walk down the street and she would need a breathing treatment. And then this is our family. In 2010, I had reached out to a gentleman at Life Technologies, introduced myself, asked if there was any way that we could pay to have Alexis sequenced. I thought we went to a conference. I heard about the advances that were being made in whole genome sequencing and discovering mutations. And so I thought that very equipment that brought us to California could actually save Alexis's life. So we engaged in a project in 2010 with Baylor College of Medicine and the Human Genome Center. Jim Lufsky, Richard Gibbs, Wojciech Wisniewski, Matthew Bainbridge, and the team sequenced Noah and Alexis. They decided to sequence the Beery twins and see if they could find the mutation responsible for their neurologic disorder. So this is us at the lab. We actually got to see Noah and Alexis's blood on the sequencing machine. And within 3 months, the team called us. We flew back out to Houston. They put us in a room. They presented a PowerPoint presentation, and they showed us the findings. And so, as you can see, the mutation is in the pathway. It's actually a mutation found on the SPR gene, the sepitarium reductase gene. And what this mutation, the findings showed us, were not only were Noah and Alexis low on their dopamine levels, but they were also low on their serotonin levels. And so with this information, we took it back to Noah and Alexis's pediatric neurologist, who was well-versed with this particular mutation. We had some options of what we could add on to their regimen of medications. We chose a more natural option, which was 5-HTP. It's a natural precursor for serotonin. We brought it on slowly in Noah and Alexis, and within 10 days of starting 5-HTP, Alexis no longer needed daily inhalation of racemic epinephrine, and within 3 weeks, she was back to running track. So on this next slide with whole genome sequencing, on the left-hand side were the steps that we had to go through to have whole genome sequencing done. We had to fill out consent forms. We had blood draws. That was it. They drew their blood, and then we gathered information. And on the right-hand side, we got a definitive, complete diagnosis for Noah and Alexis for the first time in their lives. We got a black and white answer to the mystery of their illness. We were able to add additional therapy resulting in breath for Alexis and higher function for Noah that nobody thought would happen. And we got a new life for our family. So this next slide is Alexis before. And as you can see, she had little balance. She didn't have control of her head. And this is Alexis after whole genome sequencing. This is her with the long jump, and she's pretty excited and pretty competitive, as you might be able to glance from this video. And then this is our family today. So we're healthy, we're happy, we have a completely new life. We feel with certainty that whole genome sequencing saved Alexis's life. She was every night she was age 14 and we had a baby monitor in her room because we didn't know every night if she was going to be able to make it through the night. So this is our family, and this is a personal example of what whole genome sequencing has the potential to do for other families like us.
Thanks very much, Retta. That's a really wonderful story, and we're very, very glad to have your personal experience with us today as we walk through the various components of the benefits and risks of this kind of technology. Pilar, we're going to turn it over to you.
All right, so I'm Pilar Ossorio, and I don't have any slides, so I'm just going to speak for a few minutes. And I guess also I wanted to say, so I'm actually a professor of law and bioethics, and I'm the ethics scholar in residence at the University of Wisconsin's Morgridge Institute for Research. And the previous story really was just a wonderful story in which whole genome sequencing almost certainly did save Alexis's life and perhaps her brother's as well. But right now that's the rare story. So a New York Times report on the NIH's sequencing program where they sequence people who have previously undiagnosed diseases indicated that less than 5% of people who were sequenced got any kind of medically actionable information. So we're here discussing the President's Commission's recommendation that the benefits of whole genome sequencing be made available to the broadest group of persons possible to ensure that everybody who could benefit from genomic developments will have the opportunity to benefit. I think it's worth thinking about what those benefits really are. And for very, very few people, they will actually get their whole genome sequenced, or they could actually get their whole genome sequenced, and that sequence could provide information that would really lead to medically actionable changes in their treatment, and that would lead to vast improvements, maybe life-saving improvements. That currently is a very tiny fraction of people who are sequenced, much less people who could be sequenced. And I think for right now, most of the benefits that we will be looking at are benefits in understanding diseases, in understanding how to diagnose diseases better, slow advances that lead to new drugs. Hopefully we're figuring out ways to translate genomic knowledge into medical benefit faster and faster, but still it's a complex and winding path. And the benefits of having one's whole genome, the medical benefits of having one's whole genome sequenced are still mostly aspirational for most people. There are, as the President's Commission pointed out, privacy risks associated with doing this. When one has a deadly disease, the trade-offs between any kind of privacy risks and the benefits, the potential benefits, are almost certainly always going to be in favor of having oneself or one's children sequenced. For other people who don't have a deadly disease, it's not so clear that the benefits are there right now in most cases. And so to understand benefit, we have to think about what sequencing would actually add in terms of either understanding disease or changing the intervention. Right now, for example, we have a lot more knowledge than we did even 5 years ago about pharmacogenomics, about how people's genetic variants influence the way they metabolize drugs. but it's not clear that doctors are using this information, or that they need to use this information to dose drugs, or that it would be cost effective for them to do that, or that it would really improve medical outcomes in any meaningful way. And a recent study that I've heard about suggested that at least in one implementation where an institution was using whole genome sequencing to try and understand the dosing, to try and improve dosing for one drug, it didn't really work. In other words, the outcomes weren't really improved, or they were improved by such a tiny amount that it didn't make sense for the healthcare system to invest in training doctors and implementing the sequencing protocols in order to do this. So part of getting medical benefit will be figuring out ways to use whole genome sequencing where the added increments of information really do improve healthcare outcomes. And surprisingly, we're not so far along that pathway yet for even things like pharmacogenomics. And so before we invest a lot of money in having the healthcare system sequence people, we probably need to be thinking about pilot projects in which we can develop ways for whole genome sequence information to actually benefit people. And this is particularly true for underserved communities, medically underserved communities. So the implications of the Commission's report are, I think they, this recommendation that we're discussing today, that the broadest group of people possible get the benefits, seem to be directed towards considerations of fairness and justice in healthcare and in biomedical research, and the idea that we distribute not only the risks of research fairly, but we also distribute the benefits, that is, the medical benefits, fairly. And unfortunately, in this country, we have a lot of health disparities, and so medical benefits generally are not distributed fairly, if fairness is understood to mean that people who need and would benefit from healthcare get the access to healthcare that they need and would benefit from. And so, I think we have to put this recommendation about whole genome sequencing into the context of the larger healthcare system, and say that the extent to which the benefits of whole genome sequencing are going to be widely available depend on the extent to which healthcare is widely available to previously medically underserved communities. And I think many of us on this call probably know a fair amount about health disparities. Those health disparities in the United States, we've mostly measured them according to racial and ethnic groups and health disparities. A lot of that disparity is probably attributable to wealth inequalities. And an April 2010 Institute of Medicine report, which was actually, well, it was an April 2010 IOM workshop. The report came out in 2012. It was titled, "How Far Have We Come in Reducing Health Disparities?" And that report, in its introductory section, refers to the enduring economic inequality of people of color in the United States. And its key themes that came out from the workshop are that, number one, health disparities have persisted across time and across the life course, despite a strong national focus on reducing those disparities since the late 1990s and early 2000s. We have really not moved the needle, and that recent economic downturns, starting in about 2008, had a particularly bad effect on the health of the poorest people in the United States. And furthermore, that residential segregation by race and by wealth have had a strong negative impact on the health of the poorest people and of people of color. Now, perhaps the Affordable Care Act can and will help reduce health disparities. It's not going to do that first by increasing access to whole genome sequencing, but it may help increase access to for people to better diagnostics. Those diagnostics have been developed because of knowledge gained through our sequencing research. And I think also there are a lot of questions about the extent to which people of color are included in the research that leads to these medical breakthroughs, because one view has it that if a wide variety of people are not included in the research, then the benefits will be less likely to accrue to a wide variety of people. But I think there might be something that's a little bit backwards insofar as people who are medically underserved don't have a lot of reason to think that they're going to get the benefits of any research they might participate in. So to the extent that, for instance, the Affordable Care Act improves everybody's access to health care, and particularly access for currently medically underserved populations, people who begin seeing more benefit from the healthcare system generally may then be more willing to participate in research, may have more access to knowledge about relevant research that they could participate in, may gain more trust in the system, but there will still be barriers to widespread participation in the research process. And those barriers include language barriers in many cases, but also opportunity costs. So if you are working at an hourly wage job, you probably can't take time off, or it will be the opportunity cost of doing that will be very great if you take time off to go participate in research. So it may be that we will also need, even with better health care, and even if a very diverse group of people are willing to participate in research, we might need creative ways of making it possible for a much more diverse group of people to participate in research than currently do. I also think it's worth considering what diversity means in the context of this President's Commission report and this recommendation to make the benefits of whole genome research more widely available. The implication is that they're talking about racial and ethnic diversity, and probably they are, but there are also other kinds of diversity in terms of that need to be included both in research and where we need to focus on the medical benefit that comes out of that research and making sure that everybody has access. So age, right? In order to understand how different genomic variants influence people's health, we need to actually study people across the life course. We've made some strides in including more children, but people who are older often are not included in research for lots and lots of reasons, and yet to have a complete understanding of how people's genomes influence their health, we really need to begin including more people who are older. We also need to be focusing on including more people who are poor, regardless of race or ethnicity, because living in poverty can create stresses that influence health, that influence gene expression, and so forth. So we need to understand that. So I think in terms of thinking about both inclusiveness in research and how we're going to do research that produces the greatest amount of benefit, we ought to be thinking about diversity in a perhaps more expansive way than we have been in the past, and in perhaps a more expansive way than the Commission was really thinking about it. And then the last thing I just wanted to mention is a lot of my research has been on the concepts of race and genetics, and as we think more inclusively, we need to be very mindful of not allowing our quest for diversity among research subjects in particular to reinforce antiquated notions of racial groups as having some kind of clear genetic distinctions. And we also need to be mindful of the fact that there are lots of different reasons why diversity, racial, ethnic, and other kinds of diversity may influence people's health, many of those reasons have nothing to do with genetic variation and have everything to do with different life circumstances. So, and it's very difficult to disentangle those things. And if we don't disentangle them, then the research may not actually lead to medical benefit for a diverse group of people. So in my experience, it's been very difficult for statistical claims made by researchers, where researchers will say something about, well, you know, a group of people from Vietnam has a higher percentage of a certain gene variant than a group of people from Italy. That kind of claim often translates from the research context into the clinical context in a very categorical way, where doctors will think, well, everybody from Italy will respond to this drug and nobody from Vietnam will respond to that drug. So we really need to pay attention when we're thinking about diversity and then consequent medical benefit. We need to really pay attention to healthcare provider education, which we know generally that healthcare providers are not well educated in genomics. When it comes to genomics and race, they are even less well educated. And when it comes to the healthcare providers who are serving the medically underserved populations, those healthcare providers tend to have even less access to, for instance, the latest medical advances and medical knowledge. So in order to, I think, help to carry out or help to achieve the recommendation of facilitating broad access to benefits, one of the focuses, I think, has to be on education for physicians who serve underserved communities. And with that, I'll stop.
Great. Thanks very much, Pilar. Excellent points that you bring up. And now we're going to hear from Ron Whitener, who's director of the Tribal Court Criminal Defense Clinic and senior law lecturer at the University of Washington. And Ron, sorry I got cut off when I was trying to introduce you last time.
That's okay. So to follow up really on the heels of Pilar, I wanted to talk a little bit about the recommendation 5 in the context of the work that we do with indigenous communities and genetic research. I know it's a little bit of an odd fit for me. It was an odd fit for when the university asked me. Back up one slide. My background is I'm a member of an Indian tribe from Southwest Washington, the Squaxin Island tribe, and I served as legal counsel to my tribe's tribal council for a number of years, and then went into legal services representing low-income Native Americans in Western Washington state, including assisting them to access health care before I went and joined the faculty of the law school, where I really wear two hats. One is dealing with sort of damage done, dealing with American Indians and Alaska Natives who have become involved in the tribal criminal justice system, juvenile delinquency system, or the parent abuse and neglect system. Native Americans tend to look for balance in life and nature, and so to balance that, what I've also worked in is trying to deal with the underlying issues that often lead to Native involvement in the criminal justice system, and that pathway has led me to working to try to help and facilitate, from a legal perspective, ethical research among American Indian, Alaska communities and organizations. What I wanted to look at today, I think, which was relevant to this conversation, was data from a project that I've had funded from the National Human Genome Research Institute for the last 2 years, which just ended, and we're starting to submit articles and toolkits, was to work with my tribal community to try to create a research regulatory system at that community, which was community informed. So we worked to assess the tribal membership's priorities for research, and also to measure their willingness to participate in research generally, and genetic research specifically. And research is incredibly important to tribes. I mean, there's the disparities for American Indians and Alaska Natives when we look at them among all races. When we look at rates for substance abuse, for diabetes, for cardiovascular disease, cerebrovascular disease, for violence, all of these things we see enormous disparities. And so it's important that research occurs, and the tribal communities, for a large part, recognize that research is important. But for American Indian and Alaska Native communities, that need for research has to be balanced with the history between those communities and researchers, and it's often troubled. I mean, it's often great, but there's some very notable examples, really going back to anthropology, which is really the basis for a lot of the relationships between tribes and researchers, where practices were, especially early on, more of a system of taking tribal resources, tribal remains, and very important cultural artifacts and taking them away from tribal communities. And that sort of set a little bit of the tenor between tribes and researchers. It extends into the United States radiation experiments in Alaska, where the military was doing radiation experiments amongst Alaska Natives because they thought that Alaska would be one of the main fronts in any war with Russia, with the Soviet Union. So there was actually administration of radiation to Alaska Natives without their knowledge, including to juveniles and pregnant women. There were conflicts between alcohol and substance abuse researchers in Barrow, Alaska, where the results were released without any input from the tribal community. We saw, and then in the genetic area, we've seen data sharing conflicts amongst researchers in the Nachalnut in British Columbia, where biological samples were taken, used for research purposes, and then hopped from institution to institution and shared without any involvement of the Nachalnut. And then our most recent case was the issue between the Havasupai tribe and Arizona Board of Regents litigation, where the tribe sued Arizona Board of Regents for a researcher who took samples from the tribe in a research project related to diabetes, but again, the samples left and were used for multiple things without tribal control, and that litigation eventually settled without a lot of settlement in the underlying law. But that, especially Havasupai, really put this issue on the national Native American agenda, and has been addressed several times by the National Congress of American Indians, who has also made research and genetic research also specifically a focus of their policy research center. And the thing that I like to make sure that people understand is that even with this history, it doesn't mean that tribes and Indian organizations don't want to participate in research, but that research needs to be beneficial, it needs to be ethical, it needs to be community involved and community regulated. And those reasons are why we conducted this project engaging American Indian communities in research. And one of the focuses of it was to focus on willingness of tribal members to participate in research. So we'll go to the next slide. So we used a method that's been used several other places, and I'll talk a little bit about it later. But what we did was we presented to members, they were adult members of the Squaxin Island tribe, 2 vignettes. One described sort of a generic behavioral study, and then we had one that described a genetic study. We asked the baseline question, which for each vignette, which is said, based on what you see on this vignette, how likely would you be to participate in this study? And they would then, on a Likert scale, measure their willingness to participate. So next slide. So then, there is animation. So let's go ahead and click through all of the, down to 0.8. So then what we did was we changed the vignette. We added additional information, then ask them again to measure their likelihood. So if the research was conducted by a college or university, if it was conducted by the Indian Health Service, if it was conducted by the federal government, if community members were involved, et cetera, et cetera. Go ahead and click twice. And then this isn't relevant to us, but we also were curious about where within a tribal organization they wanted to have a research unit placed. So let's go to the next slide. So a little bit about our demographics. We measured, Squaxin's not a very large tribe. We measured, administered this to 110 tribal members. We were able to, we had 15% of all tribal members participate in the survey, all adult members participate in the survey, and we were able to also involve 14% of all Squaxin elders. The tribe defines, traditionally defines an elder for purposes of benefits, someone who's age 55 or older. Okay, next slide. So what we found out is that, again, this project was after Havasupai litigation, and we found that really there was no difference between tribal member willingness to participate in either sort of a generic behavioral intervention or a genetics project. So we see, if we look at this, that about almost half of participants were willing to participate in genetic research, and then a very large chunk fell into a large chunk of 28% fell into the not sure category, and then with 19% falling into the no category. If we looked at it by age, go ahead, next slide. We see that as people got older, their willingness to participate greatly increased amongst the age categories that we measured. So 18 to 39, 42% yes, and a very large group, 38% yes, 42% not sure. But then as they moved into middle age, 40 to 54, willingness increased to 57%, and really what was mostly reduced was the not sure. It went from 42% down to 18%. A few more decided no, and then we moved into tribal elders. 67% were willing to participate in a genetic research study. Only 8% weren't sure, and then no had increased to 25%. But a much heavier willingness to participate in a genetic research study amongst elders in this community. I want to make sure that I don't generalize. I don't want to generalize this to all tribal communities in the United States. This is just this particular one. So let's move to the next slide. And I think for purposes of recommendation 5, though, I want to focus on this change if we ask them if it was conducted by the federal government. Because in recommendation 5, we see this push recommending that the United States facilitate very open access to genetic whole sequence data. That's problematic when you're working with a tribal member community. If you look at the genetic study here, if we say, is this conducted by the federal government, no moves to 48%, and yes drops to 25%. There's a huge difference between general willingness to participate in research and when we specifically drop in not the Indian Health Service, but the federal government generally, tribal members are really nervous about participating in that type of study. Real quickly, the next slide, just some other highlights of it. We see the importance of community involvement with the study. We saw a statistical increase in willingness if the community was involved with study development. And then the next slide. And then we asked specifically on something of personal salience. We asked if you or someone you know have diabetes. We see that the genetic study doesn't increase to the same extent as the behavioral study, but we do see that personal salience and benefit does have an important, is a very important factor in participation. So let's go to the next slide and go back to this issue of federal government involvement. So what's important to understand is that when we're dealing with tribal communities and urban Indian organizations, we're dealing with one on one side, the federally recognized tribes as sovereign governments who have the ability to regulate and exert a certain amount of control over research that occurs within their communities. Both the elected officials of federally recognized tribes, and the leadership of urban Indian organizations such as large urban health clinics. They're very aware of this concern amongst their members with regard to the federal government and federal government control over research. You see, for an example, you know, tribes. If we have a project where we, with the university, are working to create this. It's a software package that works within RPMS, which is the EMR used by tribes, in order for that allows the clinic to extract data from its EMR in a format that's common amongst, whether it's RPMS or Allscripts or some other EMR, allows communities to pool their data. This network that we're creating for tribes is a partner with a network that's being created by regional health clinics that aren't focused on specifically giving healthcare to any particular racial group. The data use agreement that we use is 7 pages long. The data use agreement that the regional clinics use is 1 page long. And it is this need for comfort of control over what's going to happen with these data that is incredibly important to these communities. The recommendations, I think, trigger a concern in me because I can't look at it without looking at the United States, the National Institutes of Health, the National Human Genome Research Institute's policies towards data sharing, which, especially in the area of genetic research and genome-wide association studies, is very heavily controlled by the United States. The expectation is that if the funding, and I understand it, I do understand it, it makes total sense. If the United States funds it, they think that it should be open for access, and I do understand that. The way that it's implemented, though, is that the National Institutes of Health and NHGRI is not willing to really discuss any tribal involvement in accessing these data. The data access committees, they say, they have to be all federal employees. They won't look at any special or different methods for review of access to these things. And that's created basically a stalemate, at least in that area. And so if we look at the concerns tribes have with the policies of really free access, both of them are rooted in good. I mean, the open access to this information, I understand the goal for it, but it's just at loggerheads with the concerns that tribes have with control by the United States. So how are the tribes reacting to this? Well, they're reacting in a bunch of different ways. One is they're continually battering federal policy. They won't approve, generally, research that will require them to put data collected into any open database. They are, though, conducting research and genetic research, and they are sharing data, although if we look at how it's being shared under systems of tribal control and regulation, creation of processes for researchers to be able to request access to data, and then execution of agreements if the research project aligns with the priorities of the community and has some benefit to the community, however the community defines benefit. And sharing is occurring under these processes. We're seeing a lot more analysis of how to develop tribal biorepositories. We see multiple studies throughout the country where people are collecting tribal member and indigenous attitudes towards biorepositories and how biorepositories could be structured through a regulatory system that would allow sharing. And also, there's been discussions in the future of the dream of a tribally controlled whole genome sequence database, which would operate under the auspices of a tribal regulatory system, but could be paired after execution of appropriate data use agreements with data sets that are from more open databases. And I certainly, there's a lot of philosophical issues when I do discuss this with people. I get a lot from different people of, well, I don't see the risk. I don't see the danger that tribes see out there in participating in open access to data. And my response is, well, if you're not native, if you didn't grow up native, and you didn't grow up being reminded over and over again of the things that the United States has done since colonization, and believe me, the indigenous people discuss everything back to colonization. There's been some really bad choices made by the United States. There's been some bad choices made by researchers. We've seen the use of data to attack even whether or not tribes should, as sovereign entities, should even exist. And really, I see no reason why groups and those groups are definitely out there, who challenge whether or not tribes should remain as sovereign entities within the United States, whether or not genetic data wouldn't be used as well as any other data, because any other data has been used in those arguments. And the problem is as Pilar noted, the balance scale between the risk and the benefit is still unclear. It has not been, no one has been able to articulate yet, except in specific circumstances, but they tend to be rare, whether or not this open access to data is beneficial enough for tribes to take the risk to release control to the federal government, which, as we've shown, there still exists enormous concern amongst individual tribal members in the United States. And I would like to note that while I don't want to generalize, this particular method has been used amongst patients at an urban Indian health clinic, amongst students in tribal colleges and universities, and amongst members of the American Indian Science and Engineering Society. When we look at their response to this question of, if it's conducted by the federal government, willingness always drops amongst every group that's been measured when the respondents are native. And so I think that is an issue that the tribes struggle with, and we as researchers struggle with as well. Thank you.
Thanks very much, Ron. Really rich discourse amongst the three of you, and what I want to do now is invite, we have about 6 minutes left. I think it might be good to have the three of you speak to each other first, and then if we have time to get to questions, we will. I suspect you will address most of the questions that have come in your own dialogue with each other, since you come from fairly different perspectives, and I think have the same kinds of goals in mind, but it would be good to kind of get the kind of differences on the table and elucidated. So do any of you want to begin by asking the other a question or comments?
This is Pilar, and I guess I would just make the comment that I actually don't think Ron and I come from particularly different points of view. I think there are a variety of medically underserved communities in the United States, and each community has different histories, different sets of concerns potentially, but in many of those communities there is a certain suspicion and distrust and lack and a history of being treated poorly by the medical community and by biomedical researchers. People out in the world don't necessarily make a big distinction between the day-to-day interactions that they have with healthcare professionals and between that and research. So we know that whether they're medically underserved communities or whether they are people who come from communities with very good medical care, that many people tend to kind of interchange in their mind the researchers and research processes with healthcare and healthcare processes. And I think many medically underserved people from many medically underserved communities have experienced racism, have experienced disdain because of poverty, and other kinds of overt or covert discrimination in healthcare settings, and that, I think, bleeds over into their attitudes or feelings about research, and that then goes on top of people's, specific groups' histories, negative histories with researchers. All of that said, there are studies out there that show that, for instance, African Americans have actually also very high hopes for the potential for research to improve their health. So, first of all, I think that it is possible for people to both have a higher level of distrust and a higher level of maybe belief in the potential for research to provide medical benefits. And I also don't think that a high level or a higher level of distrust always translates into an unwillingness to participate in research. I think it behooves the research community to be asking ourselves, and the medical communities, the people who are delivering healthcare as opposed to doing research or in addition to doing research, behooves us all to ask how we can structure our institutions and our interactions, our one-on-one interactions, to in ways that make us trustworthy. And some of the things that have been suggested involve more participant and or patient control over healthcare information or research data. In that regard, some of the things that Ron has found might actually be consistent with some of the ethics recommendations that, whether people are interacting with the healthcare system as patients or they're interacting with researchers, that there are creative ways that we could use web interfaces and software to give people more control over the data that were generated from them. So, and to make people more, to give people more opportunities to be, to have agency throughout a research process or a healthcare interaction.
Thanks. Retta, do you have any last words? We just have a couple more minutes.
Yes, actually, I represent the rare disease community, and as I'm listening, I'm thinking, I'm not sure. Initially I was thinking, I'm not sure if I fit in this conversation, but I realized that I really do. Rare disease, there's over 7,000 rare diseases, which affects over 30 million people. And that's the community that I work with. And for them to address something that Pilar had brought up at the beginning, less than 5% of the, I'm not sure, less than 5% of the people that were initially sequenced and got actionable benefit from whole genome sequencing is, to me, in the community that I represent, that's a huge number. If you're dealing with an undiagnosed or a rare disease and you're not getting any answers and you're going through a medical odyssey such as the one that our family went through, you're looking for an answer. And if you get an answer without an actionable path, at least you're further down the path than you were initially. And hopefully, if you get an answer, you're going to have people that are working on the disease that's found or the mutation that's found that's correlated to the disease. So with the community that I represent, I think that whole genome sequencing is a benefit in and just another tool for the medical community to have to find answers and to help with eventually, hopefully, treatment. And I think that as far as open access and sharing their data when you're dealing with especially a disease that can be life-threatening. The last concern that you have, honestly, from my perspective, and a lot of the families that I've worked with, is future problems in sharing your data, because what you're doing, your whole drive is to find an answer. Your whole drive is to save your life, to keep your life going forward. And so my comments would just be that the community, the rare and undiagnosed community, need this tool as another opportunity to find answers.
Thanks very much. So I want to thank the three of you because I think, again, as I said, I believe this is sort of the crux, obviously, of the whole process of deciding what recommendations should look like. We here at Genetic Alliance have been in the thick of this too, in the sense of saying it's really not possible to decide privacy, sharing, and data access for all individuals in a kind of blanket and uniform way. There's no one need. There's lots of needs. We heard lots of them today in this hour on the webinar. We have described and actually put together a system, a platform for engaging everybody in research in which each individual gets to choose privacy, sharing, and data access settings, and they get to change those over time because we also believe, as Ron's data showed, that people do change their ideas, their concepts, and as Retta's experience shows, when one is faced with intense suffering and even the potential loss of loved ones, the decisions one makes are quite different than from someone else who might be healthy or in a different situation. So suffice it to say, I think we've heard a very rich discourse around what the consideration should be. I'm hoping that this certainly adds to the community's conversation because, of course, the report was not the last word. And then finally, I welcome all of us to the last webinar in this series, which I think is the last. It's next month in September on the conclusions of the report. And actually, it isn't the last webinar. It's the last webinar of the report, and that'll be with Lisa Lee, who was the Executive Director of the Presidential Commission for the Study of Bioethical Issues. She still is. And Kelly Edwards, who is the Acting Dean in Bioethics at the University of Washington. We will have several webinars after that in October, November, and December that will start to look at some of the emerging issues since the report was written. And we welcome you to those as well. You can find all of this on our website at geneticalliance.org/webinars. So we'll be looking at ancestry, different contexts around the severity of disease and non-medical uses, and then the drive of technology and whether sometimes technology drives us rather than the actual clinical needs. And so again, thank you very much to Retta, to Pilar, and to Ron. And